Hello, my name is Deborah Cohen, and I am the MAVEN volunteer moderator today. Thank you all for joining us and our friends at Health Point, the Anchor Clinic, for hosting today's session with Dr. Gerald Angoff. And I'd like to tell you a little bit about him first. Dr. Angoff was most recently an assistant clinical professor of pediatrics at Dartmouth Hitchcock Medical Center in New Hampshire. There he had a dual role in patient care and medical informatics. He specializes in pediatric and adult congenital heart disease and has served as co-director of the Dartmouth Hitchcock Congenital Heart Program. And with that, Dr. Angoff, please begin.
Thank you, Dr. Cohen. The Pediatric Sports Evaluation and Screening for Heart Disease is our topic. And I have no disclosures, and the MAVEN Project does provide Category 1 credit. Objectives of the talk today: to understand what cardiac conditions may pose a risk to increased activity and sports participation, to be able to use a validated assessment tool for such evaluation, and to be able to provide some recommendations on to return to activity after illness such as COVID. This part of the presentation was a bit more critical during the height of the pandemic, but there are still some thoughts to transmit. For an outline, a bit of who I am. You've already had a bit of a summary. An overview of the sports physical examination, sometimes called a pre-participation physical evaluation. Some key aspects to identifying heart disease. Tools for such an evaluation. Pitfalls and potholes. It's never, ever simple or straightforward. Some thoughts on post-COVID evaluation, actually post-illness evaluation, and a return to activity. Summary recommendations and some questions that I'll be able to take. So think about some questions you might ask along the way. As Dr. Cohen mentioned, I most frequently was at Dartmouth Hitchcock in New Hampshire, where my focus was both adult and pediatric cardiology with a focus on adult congenital heart disease. And I had a parallel role in medical IT, working as a consultant, concentrating on process optimized workflows, quality and outcomes. And you'll probably get a hint of some of these threads as I try and develop this topic for you. Okay, an overview of this evaluation, pre-participation evaluation. And to start off with, I'd like to ask you a few questions. Hopefully this function will work for polling to get a sense of where you folks are. And here are 4 questions that we'd like you to consider. Maybe if it's possible that you can answer these, and then we might see where we're starting from. Do you perform pediatric sports screening evaluations? Do you feel comfortable doing these evaluations? Are you actually clear about what you're being asked to evaluate? And do you have the tools for these evaluations?
We're still getting a couple answers.
It's working?
Yeah, I think it's working, and I think we're not getting too many more responses, so I'm going to end the poll in a few seconds. Okay. Now you should be able to see the results. Do you have those results?
Yes, you can see them. Okay.
Okay, can I stop?
So yes, you folks are doing these evaluations, and there's a good level of of uh, of focus. So I think we've got that, and I think we can go ahead. And these, okay. So we're gonna return to these questions along the way. What about screening of young athletes? Well, certainly it's widely recommended and performed. The poll certainly showed that you folks are being asked to do such evaluations. There are guidelines from the American College of Cardiology, the American Heart Association, though this practice is variable. And develop this, and there are references at the end of the talk, and they'll be easily accessible for you if you get the slide deck, the slide presentations, and the references there are clickable. We'll bring up those references so that you'll be able to access them. Definition of an athlete. Actually, this too is really quite variable. We'll get into that a bit. Elements of screening, classically history, physical examination, and testing with a question mark. We'll cover the degree to which testing is indicated, recommended, or even helpful. What's the purpose? This too is a question worth asking, and the possible answers aren't as clear-cut as you might expect. Clearance to participate. Clearance exactly for what? I'm sure you're asked to clear your patients, your kids, but it isn't always clear exactly at what level their activity is, or for what you're being asked to say they're okay. Is it just school team sports? Low level or high level of intensity? Only team competition athletes? Athletes and non-athletes? The purpose, is it for prevention? And then prevention of what? Is it injury? Is it unrecognized illness? And specifically, is the idea to avoid cardiac events? That's often implicit, but not clearly stated. And is it for the benefit of whom? Is it the athlete, the families? Or is this really for protecting the schools or institutions? Is it the lawyers and liability? Is this really the reason why you're asked to these evaluations? So kind of take a step back and sort of say, why am I really doing this? I mentioned the definition of an athlete was variable. From the U.S. form of systematic and usually intense training. For the Israelis who've studied this whole area of screening athletes, it's really quite separate. These for those studies that are done by the Israelis, these are individuals engaged in sport activities at any level of physical endurance, from amateurs to professional athletes. It makes a big deal of difference whom you're considering. Okay, so what's the ultimate worry? Is it missing a diagnosis? Is it malpractice, those lawyers lurking? Sudden cardiac death, is this the worry? And the risk for such an event, for sudden cardiac death, has been a thread in the literature for an extended period of time. And I captured this quote from a study that goes back to really 1986, the references below. And this is sobering. Cardiovascular disease in young athletes is usually unsuspected during life. Most athletes who die suddenly have experienced who die suddenly. Most of athletes who die suddenly have experienced no prior cardiac symptoms. And only about 25% of those competitive athletes who die suddenly is an underlying cardiovascular disease detected or suspected before participation. And rarely is the correct diagnosis made. Sobering thought. What about heart diseases that might be engaged? What heart diseases are we trying to look for or identify if indeed we're out to prevent cardiac events? Hypertrophic cardiomyopathy, anomalous origin of the coronary arteries. This is a congenital defect where the arteries of the heart, the coronary arteries, originate from the wrong place, either from another vessel or from or have an abnormal course after their origin. Arrhythmogenic right ventricular cardiomyopathy. This is an inherited condition where individuals are at risk for life-threatening cardiac arrhythmia. The long QT syndromes. These are ion channel defects. There are a series that are inherited, and some can be acquired. Myocarditis and Marfan syndrome and related connective tissue disorders that would put an individual at risk for, particularly specifically for problems with the aorta, dissection of the aorta. All of these conditions are rare and easily missed with screening. Again, sobering thoughts. And just as a way of trying to capture some of these folks beforehand, there have been articles on chest pain in children and adolescents. You might hope that this would help out to identify those at risk. Here too, there is a conundrum. Chest discomfort in children and adolescents is rarely due to heart disease. In studies of thousands of patients, if we exclude acute pericarditis, it's only 0.1 to 0.2% that chest discomfort is due to a cardiac disorder. Okay, what about tools for the evaluation? There's some basics. There are forms available. And I don't know whether any of you folks are aware of these or are using them. Certainly to have a form or a checklist is reassuring and certainly efficient. We'll talk about testing and indications for referral. Basic components. History, the most powerful tool, and that's a thread that I end up emphasizing repeatedly in just about any talk that I give. Don't forget that the history is powerful and may actually provide the answers. Physical examination can help out. Testing. Testing in this area of evaluation is actually kind of controversial. We'll talk about controversial. We'll talk about EKGs and discuss other testing that may or may not be helpful. Forms and checklists. The American Heart Association has 14 elements. The American Academy of Family Physicians and the American Academy of Pediatrics have forms, and these are links to those references, and the bottom clickable reference when you get the slide deck will take you to the website where the pre-participation evaluation forms are available. You can download them, print them out, and use them repeatedly. Okay, what about the American Heart Association American College Cardiology guidelines? There's a 14-point screening guidelines, which I'll go over briefly. Screening with 12-lead EKGs or echocardiograms in association with comprehensive history taking and physical examination may be considered. This is in the guideline, may. Mandatory and universal mass screening with 12 lead EKGs and large general populations of young people is not recommended for athletes and non-athletes alike. So it's not a mandatory request. Don't feel like you have to do that, or that there's literature out there that says that this is a must-do. Here are the 14 elements from the American Heart Association, and some of them are pretty obvious, but it's nice to have a list to kind of look at and to think about. Certainly history, again, most preeminent. Chest pain, unexplained syncope, problems with exercise, prior heart murmur, hypertension. Have they been restricted from sports participation in the past or had prior heart testing as a element to delve into? In terms of family history, there are some red flags. Premature death, sudden death or unexpected death before the age of 50 in one or more relatives. Any disability from heart disease in a close relative under the age of 50. And these diagnoses in the family: hypertrophic or dilated cardiomyopathy, long QT syndrome, or other ion channel abnormalities. These are those that predispose to arrhythmia. Mark Ansley mentioned any other clinically significant arrhythmias or specific knowledge of genetic conditions that might predispose to heart disease. On examination, heart murmur, and that means a pathologic heart murmur. I hope that you have some sense of what an innocent heart murmur is and how to differentiate that from a heart murmur that may be pathologic. Murmurs in children are common. An innocent heart murmur, if you're familiar with it, is a vibratory or musical systolic ejection murmur that can be transient. It can come and go. It's usually more audible with lying down. It disappears with sitting or standing up. And this is a differentiation that you should be able to make. Femoral pulses to exclude coarctation. In pediatric cardiology, we always take blood pressures in all four extremities. You can exclude coarctation if you feel good femoral pulses. Anything to suggest Marfan's, and certainly we should measure blood pressure. This is a screenshot of part of this pre-petition physical evaluation form that I mentioned. Again, you can download it in a conversational way. Really goes after the same information I was just discussing. I really recommend that if you don't have such a tool, that you might grab this. It'll make your life easier. Okay, what about testing? As I started to say, it's not straightforward. An EKG is extensively used, but it's actually somewhat controversial as a screening component. And as I mentioned in the AHA-ACC reference, that it may be helpful, but it's not a mandate. Don't feel you have to do it. An echocardiogram is a powerful tool to detect cardiac disease when suspected, but is mostly part of secondary testing when there's already been some high level of suspicion that something wrong with the heart is there. Ambulatory monitoring, again, secondary testing, and really pursued only when there's a high suspicion, some clear history or background that would implicate an arrhythmia of substance. Exercise testing, again, secondary, and only really when it seems to be indicated for a specific reason, for a high level of suspicion that there's some cardiac abnormality. And it was part of 2 international trials in Italy and Israel, It may have been helpful in the Italian study. It was totally unhelpful in the Israeli study that looked at thousands of athletes countrywide, and stress testing just didn't help to differentiate or detect disease in the way that they'd hoped. Okay, what about referral? If screening's abnormal, and particularly the history, that 14-element list or the pre-participation evaluation form, if some of those questions fall out, then certainly seeking referral would make sense. If an EKG, when done, is abnormal, and let me qualify that it really should be a pediatric analysis. If an EKG is recorded and the age isn't put in as part of the demographics, then the computer algorithm will interpret the EKG as if it were an adult tracing, and what can be normal for a child may result in somewhat of a frightening interpretation if the computer algorithm is for an adult. It's really best if a pediatric cardiologist is interpreting that EKG for similar reasons. And I would suggest it's better to refer a patient for cardiac evaluation if your suspicion is elevated for heart disease than undertake on your own any additional testing. Okay, pitfalls and potholes. I alluded to these before. Nothing's ever simple or straightforward. First of all, cardiac disease in young athletes is rare. The measure really is sudden cardiac death. That's what we're hoping to avoid. A registry of sudden death. 26 individuals over a 26 period of time, an average of 66 per year in the United States. This is what you're looking for. And of these, 56%, barely more than half are cardiac, and other causes can include trauma, heat stroke, drugs. So screening, as I started to say, was effective in only one study, an Italian study. And it was done in an area of Italy where they had a very high incidence of inherited heart disease. And similar studies to the Italian studies done elsewhere have not shown that screening was really effective. And in the United States studies and an Israeli study that I mentioned that was countrywide, that there was a dispute, diminished the value of the EKG in reducing athlete mortality. Great idea, but it just really didn't seem to pan out. Continuing with pitfalls and potholes. Consider how many athletes, if you were going to do this comprehensively, you would need to screen if you really wanted to try to eliminate those rare instances of sudden cardiac death. It would be the order of 10 to 12 million. The low incidence of events. You're really looking for a needle in the haystack. EKG testing, which one may do. Expected, there are false negatives and false positive tests, overall in the range of 5 to 20%. This means you'll be appropriately reassured and inappropriately concerned with the interpretations of those EKGs. The cost, extensive resources required, the dollar value, versus, of course, the few events that actually are identified. Are there resources for that? Physicians dedicated to performing these evaluations, if you wanted to screen universally, and who to interpret those EKGs? The costs related to second-tier confirmatory screening. If you have a false positive and you end up doing 2 or 3 tests, the cost runs up. The concern, the the delays, the angst that goes along with it. If you then end up with imaging and other testing, is it a sequence of one test leading to another? And this overriding thought, even with testing, screening cannot be expected to identify all athletes with important cardiovascular abnormalities, the significant false negative rate. To highlight this issue, this concern, recent events, perhaps some of you are aware, last year during the NFL season, a football player suffered a cardiac arrest on TV. He probably was just hit at just the wrong time in the chest. This is a condition that's well known called commotio cordis, or just being hit in the heart. Basically a percussion to the chest in the cardiac electrical vulnerable period that can induce ventricular fibrillation. Second event, high school professional basketball prospect. Actually, he's now playing in the NBA. This is LeBron James' son, who suffered a cardiac arrest while practicing. The cause, it's unknown in the press, but supposedly he was evaluated and something was fixed, but I've been trying to find out what that was. But he had a cardiac condition that was addressed, and he's obviously been allowed to resume play. Both of these individuals were successfully resuscitated. And here's again, a sobering point. Both had extensive evaluations to include advanced testing and imaging, and all those tests were normal. These were two individuals having sudden cardiac deaths who were screened to a high and extensive level. And they're examples of the inability to predict and prevent life-threatening events, and really not justification for more screening. A few comments about post-COVID activity and an update. This was certainly much more of a concern a year, 2 years ago. Is it a special circumstance? Well, I think we could consider that at this point, the great majority of folks have had COVID infection, symptomatic or not, and many have had multiple vaccinations. It's not the illness that it was during the early phase of the pandemic. Additional cardiac screening at this point is based solely is not based solely on having COVID. At this point, it doesn't make much sense. Screening just because you had COVID at this point doesn't make any sense. So when to provide further consideration? Well, if an individual was known to have had a cardiac impact of COVID in some fashion, it's worth identifying. And during the acute phase of the pandemic, particularly, there was 3 scenarios for COVID affecting the heart, which now, thankfully, are far less frequent. Organ damage with acute illness. This is the virus likely directly affecting the heart, or perhaps a combination of viral injury, immune response, and microvascular function within the heart. Myocarditis and pericarditis following vaccination was common at the start of that first round of vaccination, and at one point was thought to be more likely after a second dose. Don't hear about it anymore. It seems to have disappeared, either because the population has changed with exposures to COVID, or the vaccines have changed. But even so, recovery appeared to be quick and full. So if somebody had that history at this point, it should not be a concern. And then there's a particular syndrome, which you don't hear about anymore, that occurred in children, which was likely an immune response, delayed immune response, similar to Kawasaki's disease. And that was a concern about to what extent it would provide long-term disability, or whether it was going to be increasingly common. Don't hear much about it anymore. But you might get in your history that someone was, that a child you're seeing later on now at what point was quite ill after COVID. And if so, this might have been the situation. Okay, what about COVID activity guidelines? Are they helpful? Not so much anymore. They were developed early in the pandemic course. They were based on consensus more than clinical data. There were no controlled studies about returning to activity early versus late. The changing denominator, right now, probably exposure to COVID is ubiquitous. The impact of vaccination and oral therapy, I'm sure, exists, but to what extent? And the stratification of COVID impact seemed early on to be based on severity, and certainly if someone was hospitalized because of COVID, that might be some part of your history to center on, because they might have had injury, direct injury to their heart if they required hospitalization, if they were that sick. Long COVID, I don't think we know much about that at all in terms of physical activity or exercise or sports participation. In 2023, there was a guideline that basically said that that athletes can return to play without further evaluation once symptoms resolve. I think that's definitely true. And testing would be reserved for athletes who have a history, a circumstance that suggested that they had myocarditis as part of testing, sort of been alluding to that with somebody hospitalized where they actually acutely ill. And that that return to activity reserved to training after 3 days of symptom, 3 days after resolution of symptoms is reasonable. Although this again was an empiric recommendation, it's probably not valid to the extent it was back then. Here's the reference, and it's a moving target. Right now, what the CDC says is that there are guidelines for recovery from a respiratory virus, and they group flu with COVID and have the same recommendations for both. So if you're going to be asked to evaluate a child, an athlete, someone participating in sports, think of your recommendations for both to be essentially the same for both COVID and influenza. And what the CDC says now, basically what I think is intuitive, 24 hours after resolution of symptoms and fever, and to resume normal activities with just some good common sense now strategies over 5 days with good hygiene and consideration for others who might be at risk. So here's the latest CDC link that basically sort of said that you can clear somebody to resume activity and sports upon resolution of symptoms and related fever. Okay, so how might we put all this together? First, primary care providers are frequently asked to perform pre-participation physical examinations, sports physical examinations. You know that. You have these patients, as you identified, coming to you, folks asking you to do these evaluations. The goals of such examinations are vague, though implicitly, or they seem to aim at preventing heart disease, at preventative screening for heart disease. The worry is sudden cardiac death, stated explicitly or not, which despite press reports is rare. Tools are available to guide evaluations. Went through them, and the links and references are on the slides. Personal and family history are most helpful. History is powerful. Cardiac testing. An EKG, if any tests are done, and even this is controversial. Little post-COVID restriction except for advanced disease, those who were truly acutely ill and hospitalized during the COVID infection, more likely early during the pandemic. And this overriding thought, screening cannot prevent most sports-related cardiac events or identify most of those at risk. Okay, well, what about some recommendations based on this, particularly with the controversies I've outlined with those sobering thoughts about the benefits and limitations of doing such evaluations. Sports physical examination should be performed with an emphasis on history. I can't repeat this enough. An EKG can be performed if history or exam raise a concern. It's not an obligatory part of what you must do. If history raised a concern and or an EKG is abnormal, referral to cardiology is appropriate. Understand and explain that a normal sports screening process cannot detect most individuals with elevated risks for acute sports-related cardiac events. Understand and explain that abnormalities identified with screening are frequently false positive. Sobering thoughts, perspectives. What I'd like to do is, if you kind of catch your breath again, is to repeat the questions that we did at the beginning of this presentation to see what your thoughts are after hearing what I've had to say. So this is our second poll. Do you feel comfortable performing the screening evaluations? Are you clear about what you're being asked to do? Do you have the tools? Hopefully, we've improved. I've gotten across some of my thoughts.
I think we can wait a few more seconds for additional responses, but we're almost there. Okay, I think I'm going to go ahead and stop the poll. Okay.
Okay, well, that's helpful. Thanks for thanks for responding. Thanks for listening.
We do have a question.
Questions?
Okay, if a patient has a family history of hypertrophic cardiomyopathy, and is asymptomatic, will they be able to participate in sports? I get this question.
It's a very excellent question, and that was clearly one of the question elements on the evaluation form. If hypertrophic cardiomyopathy is in the family, then that individual should be screened. That would be a reason to refer. What would the screening likely entail? Would likely be an echocardiogram. And the history further should try and outline who had hypertrophic cardiomyopathy. Is it a first-degree relative, a parent, or a sibling? And have any other family members had screening? And early on, with some inherited forms of hypertrophic cardiomyopathy, the pattern, the EKG, the echo abnormality is not there in younger folks and develops over time. So if there's a strong family history, it's a clear family history of hypertrophic cardiomyopathy, then that individual might need to be screened with serial echocardiograms into their early adult years. So if there is a family history of hypertrophic cardiomyopathy, then that would, I think, be a reason to refer to cardiology because of the subtleties and some of the complexities. And indeed, hypertrophic cardiomyopathy is one of the major red flags with respect to cardiac events during sports or physical activity. It's if indeed that's a condition that an individual has, their risk would be high of having a cardiac event.
Okay, while we're waiting to see if there are further questions, I'd like to thank you. That was a very clear presentation and great recommendations. I'd also like to remind the providers that in addition to these educational sessions, we also offer mentoring, both clinical and leadership mentoring, and we offer consultations. And I'm sure that Dr. Angoff is very willing, as are the other pediatric and adult cardiologists, to entertain your consults through the MAVEN telehealth platform. Another question is, in general, do student athletes get excluded from sports if they do not pass visual acuity? Not sure if that is specific to the clinic I worked at or if it is universal. If so, what acuity level keeps them from participation?
I think that exceeds my area of expertise. I'm not sure. I'm not sure I could comment. It sounds like a complex question, and it would depend certainly on the sport. And certainly, there are now wonderful athletic and competition activities available for those with disabilities, and I think it'd be worth getting some recommendations from those who would know more.
We may have ophthalmologists also as consultants, since we have more than 60 specialties represented by MAVEN. So you might want to check and see if we have an ophthalmologist that can answer that question. Any other questions for Dr. Angoff while we have a few minutes?
Let me kind of pose a question back that might give you some thoughts. Have you been in a situation where you felt uncomfortable with evaluating somebody for sports, or a situation where you were asked to to as a routine to screen anybody and everybody? Are there a patient experience that you have, but that particularly you could single out that you might want to relate, some where you might have had some questions? Anybody have an experience where they had to exclude somebody for activity and wondered whether or not that was the right thing to do?
I'm not seeing any answers so far.
There's a related type of evaluation. The pre-camp physical. I don't know whether you do any of those evaluations, summer activities that you get these forms that you have to fill out before someone can go off for some camp or athletic experience. These such requests come commonly. If you are, think about this evaluation process as a tool that you can use when somebody just asks you in general, can you clear this kid for X, Y, or Z? Just a thought.
Okay. I did look up and we do have 2 ophthalmologists on the MAVEN volunteer staff, so please feel free to ask them Lupe or visual acuity question. I think there aren't any further questions. Dr. Angoff, should we go ahead and close this session then?
Thanks everybody for listening, and I'm sure if some questions do come up, if you have a specific patient experience, or if you're in the situation of where you're not sure if you can or should provide clearance or refer or consider other testing, the whole MAVEN process is there for you. Be happy to help you out with an individual situation.
Okay, and Dr. Angoff has shared his email address there, gangoff@comcast.net, if you'd like to make a note of that also. Okay, well, thank you all for participating, and thank you, Dr. Angoff, for a great presentation. And with that, I think I'll go ahead and stop recording and close the session.